Welcome to the third webinar in the Anti-Black Racism and Public Health webinar series brought to you by the Black Health Education Collaborative and the National Collaborating Center for Determinants of Health. For those of you who were with us on February 1st and March 1st, welcome back. For those of you who missed previous webinars, know that you can listen to recordings. We will share the link with you. My name is Pema Mazumdar. I use she, her pronouns, and I'm delighted to be your host for this series. I'd like to start by acknowledging that I am physically located in Tshakake, known as Montreal, on the unceded lands and waters of the Kanien'kehá:ka Nation, a place which has long served as a site of meeting and exchange amongst many First Nations, including the Kanien'kehá:ka of the Haudenosaunee Confederacy, the Huron-Wendat, Anishinaabe, and Anishinaabe. I am speaking to you today from Tshakake, as I mentioned, from my virtual office as a knowledge translation specialist with the National Collaborating Center for Determinants of Health, or NCCDH. And the NCCDH is located in what is now known as Antigonish, Nova Scotia, in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which Mi'kmaq and Wolastoqiyik peoples first signed with the British Crown in 1725. The treaties do not deal with the surrender of lands and resources, but in fact recognize Mi'kmaq and Wolastoqiyik title and establish the rules for what was to be an ongoing relationship between nations. Slavery was established in what is now known as Quebec, where I live, through a royal mandate by Louis XIV in 1689. And in the years that followed, including when those treaties of peace and friendship were signed in Mi'kmaq, Black people were enslaved or fleeing from being enslaved in what we now know as Nova Scotia. So I take this land acknowledgement as an invitation to engage with how I can better understand the truth about colonization and racism. And in the context of today's conversation, that means understanding how anti-Black racism continues to be embedded in public health and in our status quo approaches. And it also means engaging in whatever way I can to disrupt and uproot anti-Black racism, which incidentally is the very topic of today's webinar. I'll just quickly share that after the last webinar, which focused on the social and physiological health impacts of injustice, I spoke with several of my teammates and in fact a few NCC colleagues, and you'll see the other 5 NCCs here, reflecting on various opportunities to, in our products and in our discussions, be more explicit about disrupting what Dr. Nnorom referred to last time as race essentialism, and to make the effects of systemic anti-Black racism and structural injustice more visible. So thank you to the Black Health Education Collaborative for planting and nurturing those seeds that turned into those discussions and hopefully action, and for your continued partnership with the NCCDH. I, for one, am really looking forward to this next session, and a little bit sad that it's the last one. We've had the honor and privilege of hearing from 3 excellent speakers throughout this series, and I'd like to take this opportunity to tell you a little bit more about each of them. You'll see them here on this slide, and also spotlighted as their names come up. Today, we will hear from Dr. Dryden, Dr. Nnorom, and Dr. Samiya Abdi. Dr. Nnorom is a family doctor and public health specialist. She is a co-lead at the Black Health Education Collaborative, which focuses on using education and research to improve Black health and address anti-Black racism in healthcare. She was the Associate Program Director of the Public Health and Preventive Medicine Residency Program at the University of Toronto, Black Health Theme Lead for the Faculty of Medicine, and Equity, Diversity, and Inclusion Lead within the Department of Family and Community Medicine at the University of Toronto. She is the host of the podcast Race, Health, and Happiness, and is the past president of the Black Physicians Association of Ontario. Dr. Omishore H. Dryden, she, her, hers, a Black queer femme and associate professor, is the James R. Johnston Chair in Black Canadian Studies, Faculty of Medicine, interim director of the newly established Black Studies Research Institute at Dalhousie University, and the co-lead of the national organization, the Black Health Education Collaborative. Dr. Dryden engages in interdisciplinary scholarship and research that focuses on Black LGBTQI communities, blood donation systems in Canada, anti-Black racism in healthcare, medical education, and Black health curricular content development. Dr. Dryden has published in peer-reviewed journals and book collections and has an edited collection with Dr. Suzanne Lennon, Disrupting Queer Inclusion, Canadian Homo-Nationalisms and the Politics of Belonging by UBC Press, 2015. And the co-authored commentary with Dr. Nnorom, Time to Dismantle Systemic Anti-Black Racism in Medicine in Canada, 2021, in the CMAG, which is the Canadian Medical Association Journal, and the article titled, Who Gets to Do Medicine? Black Canadian Studies in Medical Education in the Special Forum on Black Studies in Canada in the academic journal Topia, Canadian Journal of Cultural Studies, 2022. And last but certainly not least, Samiya Abdi is the Executive Director of the Black Health Education Collaborative. Over the past 15 years, Samiya has been working towards making the public health system more equitable, challenging intersecting forms of oppression, and understanding marginalization in knowledge production, research, and practice. Prior to joining the Black Health Education Collaborative, Samiya was the Senior Program Specialist in Health Equity for Public Health Ontario. Samiya possesses extensive experience in community engagement work, has co-founded international movements such as the Somali Gender Equity Movement and Famine Resisters, alongside local initiatives such as Aspire to Lead and the Toronto Muslim Youth Political Fellowship. Samiya, Dr. Dryden, Dr. Nnorom, welcome back. It's wonderful to see you all again. Thank you so much for being here. I'm going to turn it over to Dr. Dryden.
Thank you so much, and I'm just going to share my screen. Hi, everyone. Welcome. Happy Ramadan to all who are celebrating. May Allah continue to bless you richly during this time. We're thrilled to be back for our third session and twice in March, so that's a bonus. This is what we're going to be focusing on today: uprooting anti-Black racism, strategies and approaches for public health, as well as a brief overview of what we've done over these last 3 sessions. And you'll hear from all of us today. And of course, we'll have time at the end for question and answer. As well, the Black Health Education Collaborative acknowledges with gratitude the Indigenous and Afro-Indigenous peoples across Turtle Island who continue to thrive and resist colonial violence while striving for self-determination and decolonial futures. We live, work, and play in various territories, including the lands of the Huron-Wendat, Haudenosaunee, and Mississaugas of the Credit River, Cree, Oji-Cree, Dakota, and Dene peoples, the Anishinaabe, and on the homeland of the Métis Nation, Gananage, and Mi'kmaq. We remember our ancestors forcibly displanted African peoples brought to Turtle Island as a result of the transatlantic slave trade and the histories and legacies of colonialism and neo-colonialism, which continue to impact African peoples and the descendants of Black diaspora across the world. And we work in this work collaboratively with our Indigenous siblings. Of course, we are still in the decade for people of African descent, and we just recently passed the International Day for the Elimination of Racial Discrimination, which was on March 21st. And as always, all Black lives matter, including Black, queer, and trans lives. So our objectives today is to further amplify community voices and solutions to address anti-Black racism in public health, reflect on approaches to community relevant race-based data collection and use, and identify interventions and policies to address anti-Black racism. Sammy and I don't have any conflicts. But we have here all of our conflicts of interest, including Dr. Nnorom. And Dr. Nnorom, I know you need to speak to this as well.
Yes, so I do speak in many places and spaces about the impacts of anti-Black racism. Some are in educational spaces, Black and other community spaces, as well as corporate spaces, but the content is the same with regards to addressing and dismantling anti-Black racism. So I don't claim any conflicts of interest, but with transparency, put the different relationships that I have here before you.
Thank you so much. I really am going to have to update this slide. And if I could just remember what those different relationships were, I would identify them. So thank you very much. Right now, we don't have any conflicts, but much appreciated. So as with the last two sessions, this is your work, either on your phone, in notes, or on a notepad beside you. What are the insights that are landing for you during this session today? How do you feel during the learning and unlearning? And feel is important, as we've said. If you're feeling anxious or a little defensive, it will act as an obstacle to what you're learning, but it can also be an identification in terms of what needs to be unlearned. So this is why we ask you to also tap into how you're feeling. And then, of course, as we go through this, identifying what some of your next steps for learning and action will be. And as always, we thank our friend and colleague, Dr. Stephanie Nixon, who we have adapted this tool. So when we think about key takeaways, we understand that anti-Black racism is a key structural determinant of health and inequities. We know this in public health as well, that public health systems need to actively address the entrenched systemic anti-Black racist practices and policies. I currently live in Halifax, Chibuktuk. When we think about that community of Africville, and it was public health that was used as the reason to, invade that space in the middle of the night to forcibly remove African Nova Scotian people out of Africville, to bulldoze their homes. Public health guidelines were used to facilitate that invasive measure. So, and that's just one Canadian example. I know we can think of other Canadian examples with Indigenous communities, with Black communities, and with other marginalized communities. Decolonial and anti-racist action is an ongoing process. It's an active process. As we spoke about the last two times, when we think about objectivity or color blindness, those are passive responses that don't actually do anything to disrupt the racism in the room. And this is why it's important to be active in this process. And of course, requires ongoing learning and willingness to take risks. This is just part of the learning that you're involved in, and then you yourselves will engage in further learning. And it's a long haul. It is the marathon, it's not the sprint. And so apparently some folks, we were in conversation, are claiming ally fatigue. We're not a charity. This is the work that we are all engaged in, which is why it's important to understand that it's a long haul, and we all benefit. Now, the benefits we may not be able to immediately identify what that will look like. Some things are easy, right? Making sure we have greater health outcomes. And so the work, while it's difficult, is something that we'll all benefit from. Again, we want to review the work we did and we engaged in around white privilege, white fragility, and white supremacy, and how they all interact together. As we said, anti-Black racism is a system that structures opportunities and assigns values based on phenotypes through unfairly advantaging certain groups while disadvantaging others. It's also a state-sanctioned production that exploits group differences, which lead to vulnerability and subordination and premature death. And while it's experienced at the individual level, it really is a societal project and societal product. And here we really need to think about what critical race theory tells us, which is that racism, while it is ordinary, it pre-exists everything that we are engaging in. It doesn't mean that it's not passive, right? It doesn't mean that it's passive. It is an active practice that we also need to have an active response to. And of course, we can't actually get to our commitments to anti-racism, which should underlie and ground the work in equity, diversity, inclusion, decolonization, justice, right? It should underlie that work without actually reckoning with anti-Black racism. And we mentioned anti-Black racism specifically because it was activists, Black scholars, Black community workers who created what we now call anti-racism, right? That we just kind of throw about, but really came up with the tenets of what anti-racism would look like and how it should be engaged. So again, when we review the importance of disrupting white supremacy in public health practice, in public health, we see here some of the core functions and essential services as an organizing framework for dismantling white supremacy. So the core function of assessment, policy development, assurance, and then some of those practices, right, routinely tracking and reporting respondents' exposures, educating the public and policymakers on indicators of white supremacy, developing and enforcing regulations and policies to actively dismantle white structural racism and white supremacy, and focusing on critical race conceptual frameworks and anti-racist methodologies and mandates and reporting of diversity, equity, and inclusion. And I just again went over that quickly because we did speak about this in an earlier session. And then back to this point around critical race theory and understanding frameworks for public health anti-racist practice, knowing and really working actively to disrupt this reliance on race biology, especially in healthcare, especially in assessment, especially in working with communities that have been made vulnerable and marginalized. Understanding that even though race is a social construct, racism is very real, anti-racism is very real, and really working through the flow of this work and the ways in which it is connected in a cyclical process, and understanding at each step, you really need to think actively about how you will interrupt, even though it feels scary, even though you may not be quite sure of the steps to take. Not doing anything should no longer be an option, right? So when we identify the mechanisms of anti-Black racism, this is where we look at the structural barriers, the systemic barriers, the policies, the practices, those seemingly benign policies that are supposed to apply to everyone generally. That is where we're going to find systemic and structural anti-Black racism, because we're not speaking specifically about the unique experiences that Black people have in Canada historically, or that African Nova Scotian people have today. And unless we're naming it specifically, we're not actually addressing it specifically. And so again, looking at the practices, the norms, and the values that we believe are universally applied, but we know that that's not actually the effect that's actually happening. So as I just wrap up my section here, last time we met, Dr. Nnorom was speaking about racism as trauma, and knowing that the continual impacts of racism, anti-Black racism in the everyday have a physiological impact, physiological impact on the body. And so as Dr. Nnorom spoke about, race-based stress and trauma does not only occur in the context of the interpersonal encounter, but other forms of race-based traumas can include witnessing ethno-racial violence and discriminations of other people. This is why it's important to be careful what you're seeing on Twitter or TikTok, where those videos automatically replay. Why, we should choose the kind of television we watch. I don't know. There's a lot of time where I'm shutting things off because I just can't bear witness to that trauma porn. Historical or personal memories of racism, we do pass that through our DNA into the future. So how can we disrupt that now? Institutional racism, great article by Dr. Gaynor Watson-Creed in the CMAJ on institutional racial gaslighting, something to review. Microaggressions and the constant threat of racial discrimination. And then Dr. Nnorom went on to speak about how once we understand how racism is working, we know that those routine slights actually take on a greater toll. So you may be asking us, but where are you really from? But that might be the 15th time we've heard it that day and the 30th time we've heard it in the week, right? So it's not an individual engagement as much as it's a systemic engagement. And you're not the first person to ask us to touch our hair, maybe the 15th person to ask us to do that. And that is also a kind of racist harm that continues to be perpetuated against our bodies. And as Dr. Nnorom said, this can result in poor health behaviors and outcomes, serious psychological distress. I know for me, I go to cookies and cupcakes, and lately jelly beans. Apparently I'm supposed to eat salad. Maybe not drinking as much water as I should be drinking, not being able to kind of move my body, and wanting just to kind of stay where you feel safe. Like, these are the things that happen as a result and can exacerbate chronic health or create chronic health issues in our lives. And so thank you so much. I'm going to turn this over to Samiya.
Thank you so much, Dr. Dryden. And before we jump into community voices, we wanted to respond to some of the feedback that we've received from you all, and particularly highlight some of the examples of anti-Black racism action within public health, and particularly public health units. And these are just select examples, and we're sure that there's many more people who are actually making moves within public health, the public health field. And we would love to hear within our evaluation feedback forms, if you are able to provide for us some of the work that you and your teams and your organizations are undertaking, or some of the policies and procedures that you're pushing at within your own organizations. So the examples that we wanted to just highlight are particularly 3 from Ontario-based health units, and starting with the Middlesex London Health Unit. And what we wanted to highlight around their anti-Black racism plan is this focused idea of ways of working with communities. This idea of circles and not lines to begin with, and understanding that when we engage community and we want to hear voices from community, that this is not a hierarchical relationship, that it's a cyclical relationship, and that we as public health practitioners and public health institutions benefit as much as communities benefit from our services. We benefit from the knowledge, expertise, and experiences of community. Second one that I wanted to highlight is this idea of moving at the speed of trust and creating critical connections, that there's no real, genuine, reciprocal relationship without intentional building of trust. And because over the past few months, as we're going through this series with all of you, we've explored reasons for community mistrust, and why is the particular historic and current day examples of anti-Black racism practices within public health, within the public health system, and policies that harm communities. So given both the history and the current reality, it's natural for communities not to welcome us with open arms as public health professionals and public health institutions. Therefore, it is our duty to proceed with caution, with integrity, with intentionality, with reciprocity, and build that trust. Another point that I wanted to also focus, that this anti-Black racism plan had this idea of catalyzing and amplifying Black joy. Black health and wellness is not only about trauma and harm, and it's also about creating and imagining a different future, and supporting the work of Black leaders within healthcare, within public health, as well as Black communities in creating space and amplifying space for Black joy. And finally, this idea of reckoning with the past to build the future. We're not stuck in the past, as quote unquote sometimes people say. We bring up the history because there is a direct link between the historical incidents and occurrences and policies and procedures that impact how we as public health practitioners and professionals practice today. The other example that we wanted to quickly bring up is the City of Toronto action to confront anti-Black racism. And what's interesting about this plan particularly was that there was a clear and intentional vision for co-leadership and collective impact. So from the beginning, the plan was to have shared leadership and ownership with Black people, with Black community organizations, with as well as with non-Black folks and institutions. So community involvement and engagement was not an afterthought. Community, there was over 41 community conversations across the city. There is over 80 actions within that action plan that is going to go to be undertook out across 5 themes over the next 5 years. Finally, to bring up the example from Peel, addressing anti-Black racism in Peel. And what was interesting about the Peel, the public health strategy in Peel was this idea of and focus on community safety and well-being as part of the plan, as well as community investment through capacity building and change, and ensuring Black-led and Black-serving agencies in Peel are funded equitably, because we know that Black organizations are funded the fraction of what white-led and other racialized groups gain funding at much higher rates than Black organizations. Next. One of the questions we also wanted to ask, this is a critical question that we continuously ask ourselves, and we wanted to have an opportunity to invite you and your teams to ask this question. And this idea of how do we move beyond merely documenting health disparities and disseminating these findings in particularly journals on scientific forums, but instead having an opportunity to expand our professional responsibility and centering action and community advocacy. Because we know that inaction in the face of knowledge is actually a form of racism. Next. Some of the voices that we heard, particularly this work has been done during the COVID response, whereby the Black Scientist Task Force on Vaccine Equity had held over 20 community town halls, where emphasizing again that despite mounting evidence early onset of the pandemic, that despite the high mortality risks, that vaccine delivery, spread, and other measures of controlling the virus were not equitably distributed amongst Black communities. We know that Black health workers and other essential workers particularly have been impacted negatively around the conversations or lack of paid sick days, as well as job security. And finally, regardless of, particularly every single health professional, public health professional who works with the Black communities or who is Black identifying, understand that there has been a surge around mental health concerns. And we know that surge is not matched with equitable and available access to culturally responsive, safe, and trauma-informed services. Next. So the Black Health Alliance actually had launched a community consultation to hear directly from communities, Black communities, around their health and well-being. And some of the pieces that they have heard is this idea of the criticality of community connection, understanding that many Black community members live in intergenerational homes, that family and community ties are critical to Black people's health and well-being. And finally, that vicarious community trauma is real. So what Dr. Dryden was sharing, for examples, when we witness the violence that is committed against Black people, that is a vicarious trauma experience that Black people have, have to relive that over and over every time that video or that story is shared again and again. And that again impacts not only our physical health, but our mental health as well. The idea of impact and voice, and continuing to intentionally center community voices is critical. Because often the experiences of Black people and Black communities is dismissed as anecdotal, non-representative, non-scientific, and sometimes and often not objective. The next piece is around that continuously we hear from community voices is this idea of needing to center and balance both physical and emotional wellness, and having some intentionality and around creating spaces for self-care, self-love, and Black joy. And finally, this idea of accessing health and social services and being aware of what are the opportunities for growth and advancement for Black people, as well as investment within Black health services. Next. So we've talked also about this idea of, in a lot of ways, Black people are used as pawns and tokens for organizations to look like they're doing something instead of actually doing something. So this is the idea of having the Black person show up in all of the organization website and pictures and things like that, but without actually being intentional about serving Black communities. And there's also conversations around, Amisha, do you mind going back? Thank you, yeah. So there's also a lot of conversation around the experiences of Black health workers and those who are within the healthcare system. So this idea of Black professionals always feeling unsafe, not only on reporting anti-Black racism, but also bringing up ways of advancing Black health in their within their professions and within their given institutions. What we have in front of us right now is the experiences of Black Ontario physicians, so around anti-Black racism. So we keep on seeing things like othering, exclusion, stereotyping, a lack of support, and all types of aggression and violence. Next. So Dr. Dryden had kind of alluded to this or started to talk about this idea of racial gaslighting and it being a form of psychological manipulation that hinges on creating self-doubt, causing people who are experiencing real harms to second guess themselves, to feel like their experiences were not real, to minimize their experiences. And that a lot of institution actually, and that in that article that Dr. Gaynor had written, talks about institutional gaslighting. So a lot of institutions are actually invested in second guessing these experiences instead of creating policies and procedures to address them. So examples that are on the slide are things like, are you sure this has happened? Does it always have to be about race? And also bringing up suggestions that don't make such sense, such as if we've only protested peacefully, maybe resolutions would have been possible, or if you have said something in a nicer way, perhaps you could have been heard. And our friend and colleague, Rania Montgomery, who is an amazing anti-racist educator in Toronto, talks about politeness and standards of professionalism that is often used to silence and distract from the violence impact of racism. And this idea is that of nice not being the same as good, and that good requires intellectual and political honesty. And now I'll pass it on to the next slide to Dr. Nnorom.
All right. So when we think about, public health action or being able to create change, whether you're looking internally and using the mirror to look at your own organization and the lateral violence that might be occurring with regards to anti-Black racism and other forms of racism, or you're looking outward to the populations that you serve, and to understand the disparities that are happening due to racism. These are things that are core as part of what we do in public health. As mentioned before, I am trained as a public health and preventive medicine specialist. And so we wanted to bring that here for you as kind of some practical advice. So in our last session, I think folks had also asked for, resources or examples or statements that they can use to advance this work. So we were intentional about putting this quote from the CPHA position statement. So in 2018, they called on all agencies and organizations involved in the provision of health and social services in Canada to enhance public health surveillance systems by collecting and analyzing race and ethnicity data in appropriate and culturally safe manner. And so culturally safe manner is key, and ethical manner, and we'll dive into that. That position statement specifically names Black populations, Indigenous populations, and racialized groups as a group. I will say that where I speak about this, I'm speaking particularly as from the Black Canadian lens. There are unique circumstances and histories and contexts with regards to the Indigenous population where we need to use OCAP principles or approach things in a different way. But we do have an example of where there has been an Indigenous partnership. But I would say for Black communities in particular, the omission of collection of data for us as Black Canadians here has been a greater issue and a form of violence of racism, whereas for Indigenous communities, it's been largely the opposite, the over collection of data and the lack of action. So it is important to understand the different populations and different perspectives. Okay, so next slide, let's get into some data discussions. So we have to think about the data journey when it comes to the collection of race-based data. And so, of course, we want to collect, we want to analyze. With analysis is interpretation. So analysis and interpretation, how we use it, right? So how we plan, of course, we're all using, different frameworks for how we run our programs in public health, but there's the plan, the implement, evaluate. So that's how you're going to use it, but also the reports that are released, the population health assessments, or the reports on how the programs are going. And so all of that, as you see in this diagram, what's central to it is engagement. And engagement, of course, as you know, is not just an FYI, and engagement is really to involve the communities in this process, to respect their wishes where certain information perhaps is not shared, but certainly to help with the pieces around how the information is collected, what's collected, who's doing the analysis, and in particular, and we'll come to this later, the interpretation, because that is where great harm has occurred in public health overall where race-based data is collected. So next slide. So just to list some examples of data harms. So of course, it can occur at any stage of the data journey, particularly when you don't have community engagement, but also the right expertise at the table. Sometimes it is necessary actually to consult a social epidemiologist or somebody who understands the data and how racism works, who has those quantitative skills, but also those skills in understanding how these things occur. Because I would say in the past, and even at the beginning of the pandemic, where race-based data was collected, in reporting disparities, if you simply report the disparities and say, okay, I'm just going to provide the information, it allows public health practitioners and the general public to fall back on race essentialism, basically assuming that the differences are due to biology or are due to different cultures or only due to socioeconomic status. It really is critical to be able to understand the data you're collecting, involve the communities who it's being collected on, and to understand the deeper pieces. To give kind of a historical and Indigenous example of that kind of atrocious thinking that still is pervasive in public health, when in Canada, in our history of residential schools, when data was collected on how many Indigenous children were dying in residential schools, and 1 in 3 were surviving, 3 children go in and 1 survive, tuberculosis was a major factor. And Peter Bryce, Dr. Peter Bryce was a public health physician, said, we need to do something, at least he was coming from the standpoint of TB. Unfortunately, he was ignoring all of the other atrocities, but nonetheless, TB was a major factor. But he was shut down because the mantra at that time was around race essentialism, that white people had superior genetics and Indigenous children were dying because they were inferior. That kind of thinking still underlies the, when we're talking about diabetes rates or hypertension rates, those things are linked back to our social conditions. And it's not just socioeconomic status, it is the racism that is part of it. It is that trauma, that stress that I spoke about in the last session and Dr. Dryden came back to. So you have to understand the history and the social context and all of those things. So you need the people with the expertise and you need the people with the lived experience to both be at the table. So it has to be trauma informed, understanding these pieces. What Samiya mentioned around trust, moving at the speed of trust. Not all these groups are going to necessarily want to work with you because of the history of public health. So it's building that trust and understanding the historical and social context, making sure there's a lack of public accountability. We collect race-based data or advocate for the collection of race-based data, not so that we understand race, because race-based medicine or anything to do with different racialized groups and their health is not based on biology or anything like that. It's, of course, we collect information on race to understand the impacts of racism. And so there's a need for public accountability to dismantle those factors that are causing those unjust disparities in which people are losing their lives. And so lack of public accountability becomes a problem when this data is collected and nothing is done about it, as we've at times seen in the United States for African-American communities, and certainly where communities are not engaged and are not part of either ownership or at the table. So I think many, I have background in epidemiology. I don't know how many of you do, but I presume quite a few. And we were taught that the data is the data and that it is objective and that, we can rely on that. But in fact, no, what is collected, how it's collected, what is decided is important matters and can be biased. And in particular, we just have a quote here from Ruha Benjamin, scholar whose book Race After Technology really talks not just about AI, but about automation. But what we're realizing is, even where you have AI or things are automated, you can reproduce actually systemic racism and actually concentrate it and streamline it if you're not thinking critically about issues of racism and other forms of oppression when you're looking at the data. Next slide. So ethical data collection, culturally safe data collection, we need to think about the many different factors, but in particular, again, I speak as within Black communities, there are concerns about collection of race-based data, legitimate concerns based on experiences of data misuse and harm that have occurred historically here in Canada, and certainly lessons that we've seen from the United States. And so it's important, again, to move at the speed of trust and make sure those concerns are addressed. Second, community engagement, as I mentioned, is critical, right? Thinking about the questions we ask and how we analyze the data and how the results are shared, again, really does matter and needs to be done in collaboration, meaningful collaboration with community. And that means when community says no, the answer would be no, because I think I've seen engagement done in public health settings where it's more of an FYI, but whatever the health unit was deciding to do is going to happen anyways. That is a horrible way to build trust. And then simply presenting data and showing differential impacts, like we said, is no longer sufficient. It's no longer acceptable, particularly because of in our society, these ideas around race essentialism or true differences between races due to genetics or even culture or other stereotypical perspectives. It's really important to not just report the disparities, but to unpack where they come from and really get into the upstream structural factors, which include racism and other forms of oppression that drive the disparities, and then take action on those to address them. And so realizing that, of course, research does not change practice, it only changes knowledge. So even as we're speaking to, we know that that's not necessarily going to change practice. You have to kind of fully engage in this work. And when you do collect that data of disparities, then it becomes a real discussion around how to address it and how to tackle the upstream factors that are creating the unjust and unfair disparities that we see. Next slide. And just as an example of using specific principles around the collection of data for Black communities, because as I said, we're most focused on this issue from an African diaspora lens or a Black lens, then I want to make sure that you folks know about the EGAP framework. And so the link will go out in the slides, but it has 4 tenets. So engagement, so genuine, cyclical, accessible consultation with communities. So, time of day matters, how communities are engaged matters, who you're partnering with, but certainly speaking about the data collection, management, analysis, and use. And as I mentioned, you still need that scholarly academic lens at the table. So you need folks with lived experience, but also folks who understand the quantitative and qualitative pieces, as well as the social sciences. Governance, community decision-making, about engagement processes and data collection has to occur, and it's achieved through the establishment, ideally, of having community governance tables. And you would build that. So I was part of the EGAP development, and a number of folks turn back to us and say, where are these governance tables? No. This is a framework. You folks, just like any other framework, would work with community to build that governance table and resource it appropriately. Thinking about access, the right of communities to access their collective data. My goodness, at the beginning of the pandemic, when the data came out, I believe from PHAC, that Black communities were going to be less likely to be willing to get vaccinated. Initially, once I got hold of that information, I was told that it was confidential. And I said, oh, no. If this information was collected about Black folks, then it needs to be clear to Black folks and not just sitting with the OMA and CPHA and et cetera. Fortunately, once I did ask, it was clear to me that it was not confidential, but folks who are at the table were telling me it was confidential and were comfortable with that, and I was not, because that is in breach of EGAP principles and also just unethical. And then protection, the safeguarding of all individual rights and types of data, including identifiable, de-identified, and anonymized data. So of course, I think that piece, when we're talking about ethical collection of data, it should be intuitive. And so this is an example of a framework when you're working with specific communities, in particular Black community, that developed this framework for data governance. Next slide. And so just to give some core examples, so in June of 2022, British Columbia legislation, they released the first of its kind Anti-Racism Data Act. We have a data act here, I think in data standards in Ontario, but this was unique because it was co-developed with Indigenous communities. So I promised at the beginning, I said, we're not, we're speaking more to the Black lens, but this was unique because it was co-developed with Indigenous communities, as well as the engagement of a number of different racialized communities. And so it's based on input from more than 13,000 British Columbians. More than 90% of racialized people who provided feedback believed that this was important and wanted intersectional demographic data like ethnic origin, faith, ability, gender, et cetera, and felt that this would result in positive outcomes. So the Act will ensure that proper safeguards and protections are put in place. But again, it's the collection of race-based data to be able to assess the impacts of racism and take action on it. That is why we collect race-based data and should continue to do so in an ethical and culturally safe manner. And then next slide, another example from Nova Scotia is the Fair Care Project. And of course, we're coming from a public health lens, but there we've got Dr. Gaynor Watson-Creed video that you can look up online, but she is many of you know her as her time as medical officer of health in Nova Scotia, and prior to that in Halifax. And so it's a voluntary, people can opt in or opt in or opt out, but it's based on the health card, or the can be done at birth. But you basically, you opt in for your race to be collected with the health card information. And there's a clear outline on how the data will be collected. Again, that's being used for accountability, used for assessing programs and disparities, and a commitment to community partnership on every step of that data journey. And public health is under that umbrella as well. And so there is an opportunity to start to use that, let's say in Nova Scotia, for a population health assessment. But it really is important to understand that the data needs to be collected basically to dismantle anti-Black racism, to see the progress that is being made when programs are created, to evaluate programs, but it is critical that it not be used as race-based data has been used historically to reinforce stereotypes, to stigmatize communities, but it's actually used to take action, to understand that those disparities are driven by structural issues, policy issues that need to be addressed by leaders and by us in public health, making those changes. So with that, I leave that. Hopefully that is helpful for you folks in your data journey. And I will pass the virtual microphone back over to Dr. Dryden to talk about accountability and racial equity.
Thank you so much. What does all of this mean? How do we incorporate it? How do we take it on? And so when we think about accountability for racial equity, here are a couple of questions we suggest that you ask yourself. And accountability, as we know in racial equity work, is about constantly checking in with the work, right, against these set of questions. As an example, right, who's defining the work? How's it being defined? How's the issue being defined? How's the work? How will you measure success? What are the appropriate deliverables? How will you know if you're addressing the risks and unintended consequences that may play out for Black communities and other communities? How can we think about the work that we are doing and its impact and whether or not it is being effective? So over these last 3 sessions, we've really identified some of the history, the key conversations in public health and healthcare overall, the impact on the body. All of those things come together and work in tandem for these questions and actually doing the work. The other part is we're often outward facing. How do we do this work out in community? How do we do this work so it's effective? But there's inward facing work that we need to do. And I don't only mean individually addressing, how you engage with your own white supremacy or your own white fragility or your own white privilege or lateral violence. For those who may be non-Black people of color, how do you also engage with identifying your own stereotypes around Black people, Black health, and anti-Black racism, but also how does this happen in the work, right, in the institution? So when we speak to various agencies and groups, we talk about the importance of refusing the all-white shortlist. I don't know if we spoke about this last time or the time before, but when we look at the ethno-racial diversity of your region, of the nation, at this point, having an all-white shortlist only further serves to perpetuate white supremacy and white privilege in the workplace. So while you might think intellectually, I don't, in terms of believing white supremacy is about believing in the supremacy and the importance of one race over the other. Intellectually, you might be like, I don't think that, I don't believe that. I do believe that we're all just people, there's good, there's bad, things of that nature. But you will animate that you actually believe in the supremacy of one race or one ethno-racial group over another when you have things like all white shortlists. Why is that? Is there, the self-reflection is, are we actually accurately assessing the resumes or the CVs when they come in? Are we able to interpret the data on those CVs or on those resumes and whether or not they'll be applicable to the work that needs to happen or will happen. And so the all-white shortlist is two failures. One, the inability to assess accurately the resumes and the applications that have come in, as well as this continued support of the supremacy of one race over the other. You know, the purpose is not to hire someone like everyone else, like that's already there, but really to change the work environment so you can change the outward facing work. And it also means that you're diminishing the Black tax and making sure that there's not just one or two people responsible for all of the work of Blackness and in addressing anti-Black racism. The other piece that we provide for you is how, because if we're only thinking of this work outwardly, what it does is that serves to kind of occlude or keep in the shadows what's happening internally. And so part of that is, how are you addressing internal complaints of systemic anti-Black racism or anti-Black homophobia or anti-Black harassment and discrimination? How are you addressing that internally? Are there complaints? And if not, why not, right? When complaints arise, they come up because there is a belief that there will be an appropriate response and resolution. If people are not complaining, it's because they no longer believe their workplace, A, has an interest in creating a supportive work environment, or that they will only end up being pushed out and retaliated against because they raised complaints. And so this is why it's important to think about the internal complaint process, internal to your office, but also because how that works is a measure for how, for example, community members may have complaints about public health officers or practices. And if that doesn't work well, then how can we overall address systemic anti-Black racism and anti-Black harassment discrimination? As an aside, anti-Black racism training is not necessarily an appropriate response to a complaint procedure. We really need to think about more accountability measures when resolving complaints around anti-Black racism. And I have an example for you. But before we get there, I want to identify the work of Professor Sarah Ahmed, who was a professor of race and cultural studies at Goldsmiths University, University of London in the UK, having been previously based in women's studies at Lancaster University. And it's important to note that she resigned her post at Goldsmiths in protest of the failure to deal with the problem of sexual harassment. She's also a race scholar and does work, you may know her work through feminist killjoys. You may be familiar with her work that way. And I'll provide you some resources of her work in a moment. But there's a couple of things that's important for you to note that she talks about specifically around people who raise complaints or raise concerns. Often those who raise the problem, right, identify there's a problem happening, are often then assumed to be the problem, as opposed to actually focusing on the problem that they raise. I'm sure you've had those experiences or you've seen when that's happened. We know, and there's a whole cascading response to that. Also, as I said, a complaint can come out of a sense that unless you complain, the same thing will keep happening over and over again. And so people complain because they want to stop a particular behavior, action, or practice. And that's why they're raising the complaint. And so it's a gift. It's an opportunity to be like, oh, something's not working. How do we fix it? And if you can do that effectively within your agency, within your workspace, then you can do it more effectively within community. And then we could do it more broadly, more effectively in public health throughout. So this example of a really great policy is disruption of all forms of racism policy that was approved at the University of Manitoba in their Faculty of Health Science, which includes medical school and other areas of health. I think it also includes public health. And so they set out a duty for individuals internally on how to address systemic anti-Black racism and other forms of racial discrimination, harassment. And one of the key things that they raised is there's no wrong door. So if somebody comes to a person and says, I have a complaint, I have a concern, or there's a problem, that person is now responsible for making sure that an appropriate measures are put into place. So there's no wrong door, and that is key. Here's an example. They also provide an example of 43 examples of what racism can look like. And that's just a small number, right? Because they were seeing that people were like, oh, that's not racism, or that's not racism. Like, no, here are just some examples of what racism looks like. So we often think about racial epithets. We use this in the earlier sessions where we said, what does white supremacy look like? And it's always those things at the top, but what are some of those more sublime or subliminal pieces? Failing to deal with racial incidents or downplaying the seriousness, right? Racial gaslighting, exclusion from formal and informal networks, right? Ostracizing. These are just some of the examples of racial racism. But again, here's an example around accountability when resolving this complaint. So yes, you can ask someone to attend educational sessions on anti-racism or specifically in addressing anti-Black racism, but it must be accompanied with evidence of learning. So what would that look like? It must be accompanied with evidence of learning. It can't just be, oh, you went to 2 hours, you're done, everything's good. But what did you learn? How can we measure that? And how will you put that into action, into practice? So here's an example. It's a medical example, but it's one that we can learn from about how not to do this work. So you might be familiar with the white surgeon in Alberta who hung a noose outside the operating room while a Black surgeon was about to go in and operate. It took many, many months and a lot of action nationally from Black physicians and Black healthcare workers to force the College of Physicians and Surgeons to appropriately investigate this case. But even in that moment, they did not investigate it appropriately because they had no one on staff who had experience with addressing systemic anti-Black racism and this kind of racist harm. So you would think that they would step aside, but they did not. They chose to set aside the racism and instead reflect on this interpersonal issue. And I want to say, if you're understanding how critical race theory works, you cannot set aside racism. In doing that, what you're doing is furthering the racism. And so we could talk a bit more about this in Q&A. I want us to get to that moment, but understand, if you do not have someone in-house who has these this kind of experience, it means that you are not qualified to investigate this complaint, and you must go outward, and you must hire people with that expertise, and you must begin with the racism and not attempt to try and get to it at another time. So as I said, here are some resources for you. Dr. Sarah Ahmed, or Professor Sarah Ahmed, as I said, has written these 2 books on being included, racism and diversity and institutionalized, in this book, Complaint. When I ever hear that a colleague is starting work in the Human Rights Office, I gift them this book. And if I ever hear about someone who is initiating a complaint, I gift them this book. These are the 2 books that will give you an overstanding of how these systems work. This book in the middle is about equity in universities, but is applicable to all institutions. And it talks about the all-white shortlist. It talks about the ways in which commitments to equity, diversity, and inclusion are undermined because of Eurocentrism and continued white supremacy. And thank you very much. We will wrap it there and move to, sorry, before I do that, this is where you can find us. And then we will move to questions. And I'm going to stop sharing my slides at this time.
Hi again, everybody. So thank you so much for that. Wow, there have been a few questions already that have been posed and answered. And I'm just seeing, Dr. Nnorom, that you'd indicated that that you'd answer a question live. Do you want to just go ahead and do that before, and maybe we'll give folks some time to populate this question and answer board. So I'm just going to invite all participants to, if you have questions about disrupting anti-Black racism, it would be great if you could start to populate that question and answer board. And I'm just going to turn it over to Dr. Nnorom.
Yeah, so the Fair Care Project, I'm actually going to defer to Dr. Dryden. Interestingly, I did a rotation, public health rotation in what was known then as Capital Health in Nova Scotia, and I don't know, I was PGY5, it was a long time ago, but those were the initial discussions actually that were going on the, how to collect race-based data and have it linked to health cards. So just to say, at least part of the context is this is a decade in the making. The question was, why was it an opt-in rather than an opt-out? But again, because this had been negotiated and thought about and pushed back and for so long, I presume that's part of why there was a hesitance to make it an opt-out, and that was part of the compromise, perhaps. That often it's not uncommon. But I'll hand it over to Dr. Dryden, who hopefully has more recent information than I had 10 years ago. As far as the background process.
Right. You nailed it. It absolutely is about part of the compromise that was made, but not just with government, with community. And so government was really dragging their heels, as Dr. Nnorom has just said, but community also was really concerned about government access to their information. And as Dr. Nnorom said, you really do move at the speed of trust. So there's a couple of things that are in place that I'm involved in. I work with other Black community leaders around governance and access to data and what that governance sharing and governance model will look like. And so we meet regularly to review the policies and protocols that are being put into place around data collection, data sharing, and governance. So we meet every 6 weeks ago to review the documents and give insight. And part of the data governance, data sharing is who gets to approve the sharing of the data and what is the hierarchy of those approvals. So going through ethics and then reaching out to the Fair Care program to get the data, but then also having to have approvals from Black communities, Indigenous communities, queer communities, other communities, because it is quite diverse data that they're collecting around our identities and our bodies. And then the other piece is around really developing the security of the health data. So I'm working on that committee as well. Our hope is that as people increasingly volunteer, as you saw, Dr. Gaynor Watson-Creed, who's also a board member of BHEC, was involved in early health promotion around the importance of collecting this data. So we're hoping that as people sign on, that over a period of time, we can then move towards an opt-out process as opposed to an opt-in. But there is quite a bit of work moving through historical African Nova Scotian communities in Nova Scotia and going through the province and meeting with Black communities and really developing this trust in terms of which is working, but again, through governance sharing and data sharing protocols, which would be new.
Great, thank you so much. That's perfect. So I think there's quite a few questions that have been posed throughout the webinar on wanting to know more about the resources that have been shared or where they've come from. And I just want to assure everybody we are going to follow up, as we have been for the last 2 webinars, with an email linking to lots of different related resources, any articles that have been mentioned, the books that have been mentioned. Don't worry, we will get them to you. I know everybody's reading list is getting longer and longer, but also hopefully lives are getting richer and richer because of it. So thank you. I just want to share that there's appreciation for this webinar from Makeda Kafeli Green, who says, forgot to mention that I'm a proud young Black woman and wants to thank all of you for the session that's been so informative. She's a 3rd-year health studies student at Laurier, hoping to go into mental health. It's rare that I see those comments in the chat, so I just wanted to call it out. And there's another question from Marion Wason McIntyre, who says that she's very new to Canada, living in Saskatchewan, works in public health from a health promotion standpoint. She noticed a lot of the examples given about Black targeted racism come from Nova Scotia and Ontario. Are you aware of what is the situation in Saskatchewan? She is apparently one of 2 Black persons in her organization and would like to know a little bit more of what to look for or be aware of. So I don't know if there's anything that any of you want to say. Dr. Nnorom, go ahead.
So, I mean, I don't know firsthand what organizations are looking at anti-Black racism in Saskatchewan, but usually there are community groups, and it does make sense to connect with any group or community groups, even where, because I think in Saskatchewan, the Black population is about, I think 0.5%. It's quite low, right? So it's a little bit harder, but there will be opportunities to organize and work with other professionals. So I would recommend that. Within the history, though, of public health in Saskatchewan, there has been work to address racism broadly, but not necessarily anti-Black racism. It was a really great historical example where when public health was regionalized in Saskatchewan. Now it's provincial, but the people still exist. So in Saskatoon, if you can find somebody who worked at the health unit in Saskatoon, really great work by Dr. Corey Newdorf, which was based on looking at Indigenous issues, but then it actually became a much more broad project around racism and addressing racism. They were really ahead of their time. So in 2012, they conducted what was called a intercultural development inventory. So they had consultants come in and actually do an audit of individuals and the organization. Based on that, they recognized that they needed to build their capacity. And so this is where the anti-Black racism kind of understanding comes in, because then they started to have sessions on anti-racism. And of course, as Dr. Dryden said, you can't really address anti-racism without anti-Black racism in there. So there was some of that in there. Cultural safety, like they increased that, but then they went beyond it in their programs. So internally, their hiring practices, they changed their hiring practices, despite all of the, policy challenges there are with hiring and unionized environments. They were able to bring on more Indigenous and underrepresented groups to work in the health unit, and then began to have programs and have impact, like immunization programs and other programs that used an anti-racist lens. So that was from 2012 to 2017, but then all of that kind of ended, unfortunately, because it was no longer regional, it became provincial. But I think if you want to speak to those folks who were at the Saskatoon Health Unit, it becomes a concrete example of doing that internal work, doing the audit, changing practice, hiring and changing the people within, and then doing the work externally. So that was from 2012 to 2017. So I would recommend that. And then always do not do any work, I would say, around anti-Black racism by yourself. You will either burn out or get sick. So you need to organize with others, even if it's outside of public health, what's going on in the hospital, or even if it's Black accountants, whatever it is, find folks who can support you, or like-minded people who are experiencing other forms of oppression, who will be in solidarity with you, not speak for you, but be in solidarity with you.
Thanks. And, I think that's a really good place to ask Samiya to weigh in on, to expand on that, because there's been another question asking how can young Black people who are in the workplace navigate the racism that they will face.
Yeah, so thank you, Dr. Nnorom. That's really a good advice. And just to continue on that work, for young, old, middle-aged Black folks who are working and existing and thriving within these organizations, the first piece is that it's not always your role to actually fix a system that has been broken and designed this way. Sometimes we take on that responsibility because we feel like we don't have an option, but you do have an option to try to disengage whenever you can. But if you choose to actually engage and try to make change internally, yes, find a community and mentors and supporters and strategizers and co-conspirators who are Black outside of your organization, perhaps some in your organizations. The second piece is if there is allies within your organizations that can amplify your voice, or sometimes not speak on behalf of you, but bring up these conversations in spaces that you are not present in. See if you're able to do that. The other part is, if you are taking on this work, try to see if this can become an official role, or if there is a role definition that can be shifted, because sometimes people are doing this work from the side of their desk. They're burning out, they're putting in a lot more energy while they still have to operate within the circumstances that they were hired under. And then I think, Pema, there is another question that is relevant to this around this, the surge of hiring EDI expertise, and almost pitting people against each other, whereby folks are being hired for that role where there has been maybe Black folks within organizations that have been leading the work from the inside, and so those people being sidestepped. Sometimes the way white supremacists operates is exactly that the pitting against each other, and choosing people who are maybe less vocal, people who are kind of are worried about the security of their position, and all of that. So recognize the game and understand that this is part of the strategy. And also try to see, again, if it's very challenging for folks if they are not at a decision-making place, if they don't have the security within their organization to be vocal and critical about the internal practices, to bring this up. But also, you know, do a real assessment of how much of one of the things when the Dryden was starting, one of the objectives for us to take away from these trainings and conversations is that assess and be able and willing to be taking risks, but also assess how much of this risk taking is just a conversation at the end of the day, and which one of these risks are going to result in, you know, the loss of your position. And if you're going to go ahead with that, you know, just go with your eyes wide open to make these decisions. And I'm gonna maybe invite Dryden or Nnorom to see if there's anything else.
Yeah, I think that all of that, I would co-sign all of that. So we have seen this, you know, the other nuance to this question is that often Black people, because we're talking about Black communities, are often put into positions that are specifically about equity, diversity, inclusion, they don't call it anything else, they call it that. As opposed to in the university, for example, they would create an associate vice provost or associate vice president equity or vice president equity. And that's where you see Black people going, as opposed to promoting Black people to provost, vice president academic, vice president, finance, president, right? So we become put into these positions. It's why I push against saying I don't do equity work. I do Black work, I do anti-Black work, I do anti-racism work, but I do not do equity work. The other part about that is we've just seen the data and the stories where there's been a huge layoff of all these new hires to equity, diversity, inclusion, and the resulting staff are primarily white women, right? And so I don't think we talk enough about the nuance and the role that white women have been deployed in to prop up harmful situations and prop up systemic barriers and systemic harm. We don't do enough of that work, and there's lots of research and data out there and scholarship that speaks about this unique role of white women in this work, in colonialism, in slavery, and in anti-Black racism. But I also want to add, sometimes the work, I agree with Samiya, sometimes the work is not to try and make is not solely to make the institution better, but it really is to work within our communities to provide us strategies and supports for navigating these harmful situations. And sometimes that's where we find liberation. We find liberation and we find transgressive change in the work that we do in and amongst our communities to intervene and interject against public health, against health systems, against these harms that continue to be perpetuated against us. In terms of the TCPS2, I do want to acknowledge our colleague, Dr. Barbara Hamilton Hinch, African Nova Scotian woman from the historical communities of Cherrybrook and Beachville, also a board member of the Black Health Education Collaborative and someone I work with quite closely. She has really been working to update the TCP S2 for years, trying to get funding to provide, so she could provide the educative materials needed to update, that process. So if you want to reach out to her, she's at Dalhousie University. She would appreciate any kind of support to push this along so that we can change and update the TCPS2, which is over needed, right? Overdone. And my shout out to the BC folks. There are a lot of Black folks in Victoria and in Vancouver, and when I mean a lot, like relatively, who are working on these kinds of interventions. And so if you don't know them, find them, work with the folks who are doing outreach, who are intervening for safe injection sites, who are Black, who are doing historical work around saying, no, we've been here. I lived in Victoria and Vancouver for a brief period of time, but there are folks that are doing that work. That's where the health advocacy is happening in lots of areas. And that's where to go to be like, how then do we work as a collective group to make these interventions? But they're happening, they're involved. So that's what I would suggest.
Thank you so much. And just in case folks missed it, Dr. Dryden was just answering a question about whether there might be a chapter in the TCPS2 to guide research ethics with Black populations, similar to Chapter 9 for First Nations, Inuit, and Métis people. And there's so many questions in the chat. I was just trying to look through them and see how to aggregate them. Some of them have been answered already really well. So I'm just there's a question from Gilbert from in Montreal. He's asking for a more detailed request, I think, for a consultation. And I'm just gonna say, if anybody has a kind of request like that to the Black Health Education Collaborative, where you're looking for outside expertise or want to be connected to somebody who would have the right outside expertise, we'll share their contact information again at the end when we share the evaluation link, and please do write them directly with that kind of request. I think it might be easier than trying to address it here in this webinar. And they're the right people to write about it as well. And then there's a few questions here from there's a question from a person who says, I'm a white person, and at times I find it hard to speak up when when is it appropriate to speak up or give space for Black folks to speak, etc. Do you have advice for how to create space for Black people in your organization to take that space? Wondered if you wanted to comment on that.
I'll start and then maybe hand it over to my colleagues. I'm just going to give real life examples. I think there's two parts to it. There's going to be tables as a white person or a white leader, I presume a white leader, where you will sit where there will not be any Black representation. And so that is a situation where A, you might raise an issue, but also B, say, look around the room. Why isn't there, Black representation here? So there's two parts to that, like raising whatever the issue is, and then raising the fact that there isn't somebody in the room. Where there is somebody in the room, then it becomes engaging in those conversations before, during, after. It really depends. It's a bit of a dance, Sometimes a Black colleague will raise something, and it's helpful to say, yeah, I agree, right? To use your white privilege and your white voice. Sometimes it's not safe for them, and it depends on the context. Maybe you might bring it up, or you might speak to them after and say, do you want me to bring this up afterwards? So in situations where we're not there, it's helpful to actually speak up and also say, how come somebody isn't here to speak? So amplify those voices and bring them in. And where we are there, then it's more of sometimes it's side conversations to say, okay, how can I help? So that's what I would add. I don't know if my colleagues have anything further they want to add as well.
I would just say we've all gone to meetings that we have pre-strategized with colleagues before we went into the meeting. So pre-strategize with your colleagues before you go in. We've done it in other cases. So pre-strategize with your colleague before you go in, especially if it's an ongoing long-term conversation. But we've done it. We've done it in any of our other department meetings, faculty meetings, community meetings. And so it's a tool that would be useful for this as well.
The one last thing that I was going to add is if the your Black colleague is the one that is bringing up the issue, it could be a response, like a real-time, in-time response. Don't wait till the end of the meeting to pat them on the back and say, oh, that was very brave of you, or email them privately. Share that, your support for their voice and amplify their voices in the meeting. So provide that real-time support, not privately, but publicly.
Yeah, and reply all to emails saying the same thing, so everybody hears the support.
Yes, definitely. I see there's a question about the Black Legal Action Center and healthcare. I feel like that might be an email directly to us. This is a pervasive issue, and so yeah, we will be happy to answer from the legal query about Black patients being mistreated, but it's more of a complex question.
Thanks, Dr. Nnorom. So we will look through that chat box and make sure that we get anybody who was asking for that kind of contact information. We'll make sure we get you the Black Health Education Collaborative's email and contact, even if you don't see it in the last slides here. And all of the resources that were mentioned, we'll make sure we get those to you too. I just want to turn it over. Thank you so much to our panel. Thank you so much to our speakers for this whole series, for the partnership. I will have the opportunity to provide you with the evaluation link, and thank you again at the end. But just right now, I want to turn it over to our scientific director at the NCCDH, who's going to share some words of reflection and our own organization kind of commitments around this work.
Thanks, Pema. And I think you said, Pema, wow. And so I'm just going to say it again. Wow. Thank you so much. I'd like to start just by saying my own thanks to the Black Health Education Collaborative for their incredible partnership and collaboration on these webinars. And I really want to acknowledge our colleague and friend Sume Ndume Ayo for her vision for this series and for really putting plans in place before she left on leave from her position as the director of the Black Health Education Collaborative. Just a little fact, these 3 webinars, I think, drew the largest registration in our 15-year history. And I think that speaks volumes about the reputation of the 3 esteemed speakers, Samiya Abdi, who's been a longtime friend of the Collaborating Center, and Dr. Omishre Dryden and Nnorom. Thank you so much for what you brought to these 3 webinars, but also to your whole organization. I heard many times you acknowledge your board, your partners, and your collaborators. So thank you. And I see a very strong and valuable future for the Black Health Education Collaborative, one that we really want to continue to be part of. I think that registration also reflects the interest and commitment in the public health community to learn and unlearn about anti-Black racism in particular, and to commit to action and then act on that commitment over the long hauls. So a few takeaways for us, and I'm just going to go back to what Dr. Dryden had up there, and then I'll speak to our commitment. Racism is a key structural determinant of health inequities, no question that it exists, but it also exists in all public health organizations and systems of systems across our country and around the world. Public health systems and the public health system itself must address the entrenched racist policies and practice, both historical, and you touched on that, a very small amount. You could probably spend an entire 3 webinars on that, but historical and the current racist policies and practices that exist in public health. And we need to hold ourselves and each other to account in disrupting those. Decolonial anti-racist action is an ongoing process, and I loved that it goes at the speed of trust in our systems. And we all in public health, wherever we are, wherever we work, have multiple opportunities every day to build that trust, to nurture that trust, to protect that trust, to practice reciprocity, and to center community action and advocacy to disrupt anti-Black racism, as well as racism and all forms of oppression. Take away that it requires ongoing learning and unlearning and willingness to take risks, and that there's a direct link to the history of colonialism and racism, and there's so much to learn and unlearn. But we do collectively have an opportunity to create a vision of co-leadership, co-ownership, and one of real community involvement and engagement, always right from that get-go. It's not a sprint, it's not a quick fix, and we really do need to commit to the long haul. However, I heard in these 3 webinars that change and getting better and going for joy and healing and hope is possible. So thank you for that. And we will all benefit. I agree with that. So we know that anti-Black racism is institutionalized, it's embedded, it's maintained in our policies, our practices, our systems, and our strategies. So it stands to reason that systemic racism is alive and present in our organization, in the National Collaborating Center for Determinants of Health, in our knowledge and evidence gathering, our synthesis, our exchange, and our sharing, as well as in our services, products, and in our hiring practices. So given what we've heard and learned in these 3 webinars, I think we have to assume and name that the problem exists in all public health organizations, and we all need to grapple with and take action, both individually, but also collectively. So the NCCDH is committed to get better at seeing racism, where racism manifests itself, specifically anti-Black racism. And we're committed to increasing our knowledge, our skills, and attitudes for disrupting it, including examining and shifting our structures, our policies, our systems, our norms, and our values. And one opportunity that we have right in front of us, and I'll only name the one, and it's an outward one, is that the collaborating centers, all 6 collaborating centers, have been commissioned to work to refresh or modernize the core competencies for public health practice in Canada. And I think that is a huge opportunity for us to embed and ensure that those knowledge, skills, and attitudes to disrupt anti-Black racism, racism, and oppression are clearly stated and strongly embedded in that set of competencies on the way forward. So again, I look forward to collaborating and to partnering with the Black Health Education Collaborative in the future. And thank you again so much for what you brought to these 3 webinars and to our public health community. Thanks.
I'll just echo those thanks. And I know it's 2:32, we're 2 minutes over time, but I just want to thank those of you who are still with us.
Pema, you're on mute.
Oh, sorry, I'm on mute. I was just saying thank you to so many people who brought the series together, and to point you towards the evaluation link, which has been shared in the chat box. It's a team effort. I know we're a little over time over here, but I'm just going to say huge appreciation to the Black Health Education Collaborative for their expertise and partnership. And last but not least, thanks to all of you for engaging. Please continue to engage by filling out the evaluation, by continuing to do your learning and unlearning and translating it into action within your public health organizations and the larger health system. And don't hesitate to be in touch with us or the Black Health Education Collaborative, or I should say, and the Black Health Education Collaborative as you go about that work. All the best to all of you. Thank you.